Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the first session of the peer learning periphery to the fore 2023 online case discussion by the physicians away from the center. My name is Dr. Anomali Shilpika Vidanagamage, the moderator of the today event. We know that the physicians working in outstations with limited resources have evolved excellent clinical skills in patient management. So there is a lot to be learned from them. In 2022, CCP introduced an online case discussion called Peer Learning Periphery to the Fore to share the knowledge and experiences of physicians who work away from the center bi-monthly. Since this year, CCP decided to conduct this session monthly since this year. First of all, I would like to invite the President of Ceylon College of Physicians, Dr. Duminda Munidasa, to talk few words about this session. Over to you, sir.
Thank you, Rohita. Thank you for organizing this. And gives me great pleasure to be part of this program, the first one for 2023 as the President of the college. The Periphery to Fore, as Rohita said, was started last year, and it has given a great platform to discuss clinical cases which are managed from periphery with limited setting. As you know, with a lot of constraint, our theme this year will be the holistic care delivered amidst constraints, which we are facing a lot. So I think we can learn a lot from the periphery with limited resources, how you all are performing and looking after your patients. So I'm very grateful for Dr. Anomali Vidanagamage and Dr. Lakmal Vithanage for joining today to give the wisdom they have gathered through their patients enable others to learn from that. And my special thank again for Rohita, our main coordinator for this event throughout the year. And will be supported by the Merck from MRChemie. We are very grateful to them for supporting us, and Nalina and his team, as well as my co-secretaries for arranging all that. So I'll hand it over back to Rohita to conduct the program. Over to you, Rohita.
Thank you, sir. In this session, two physicians present and discuss clinical cases in our 1 hour period. Today, we have two consultants from Base Hospital Ambilipiti and Base Hospital Udugam. At the end of the both presentations, we will discuss the questions received from audience. Please send your questions to Q&A box. Let me to introduce the first speaker today, Dr. Anomali Shilpika Vidanagamage, consultant neurologist, District General Hospital, Ambilipiti. Dr. Anomali Shilpika Vidanagamage, MBBS, MD, MRCP Neurology UK. She won the College of Surgeons Gold Medal for Surgery at Final MBBS 2011 and Gold Medal in Clinical Medicine at MD 2018. Her overseas training at Kingston Morley Regional Neuroscience Centre at St. George's University Hospital, London, UK. She presented at several international forums and contributed to a few articles. Her special interest is stroke and neuromuscular disorders. She is going to present on hyperacute stroke management at the periphery. Over to you, Dr. Anomali.
First of all, I would like to thank CCP for giving us this opportunity in this peer learning experience to share our experience at Periphery. My topic today is hyperacute stroke management at the Periphery. I would like to start and go through with a few cases, and my main objective today would be to go through the hyperacute stroke management, mainly the hyperacute acute thrombolysis process, and how we should approach patient identification and proper management and referral to the particular center, and how we should look after such patient. So all these cases, we've started thrombolysis 2 months back at District General Hospital, Amalipitia. So the cases I'm going to discuss today are cases we had within last 2 months. So the patient one, I would call him Mr. A. He's a 62 years old male with diabetes and hypertension. Came with sudden onset right upper limb and lower limb weakness with slurred speech since 2 hours duration. And he was fast positive. I will tell what that is. And NIHSS score was 7, and the initial non-contrast CT didn't show any visible infarctions or bleeds, and the aspect score, I will tell what it is later, was 10, and there was no contraindication for thrombolysis. So thrombolysis was done, and post-thrombolysis NIHSS was 1 due to a partial facial asymmetry, and it was a good outcome. So here, so I hope I meet a broad audience in this webinar. So first, we all know that a stroke is a sudden onset neurological deficit as a result of cessation of blood supply to part of the brain. So there are 2 types of stroke. One is ischemic stroke, which is 85% of strokes are ischemic, and the rest is hemorrhagic. So mainly due to intracerebral and a small proportion due to subarachnoid hemorrhages. And the ischemic strokes are due to thrombotic and embolic phenomena. So due to cessation of blood supply. And the corresponding area of the brain is ischemic, so that it will result in weakness. So this is a very important slide. I would like to highlight that time is brain. So in the very first graph picture, there is a area highlighted in black, which is the core of the infarction when there is ischemia. And the area in blue is the area at threat, which is called the ischemic penumbra. So every minute, every second counts. So in every minute, 2 million brain cells are lost due to ischemia. So this core, which is the infarcted core, will expand in every second. So the area at threat or the ischemic penumbra will be lost in every second. So time is brain, and we need to attend as soon as possible to salvage the brain. So what are the treatment options for acute stroke? So thrombolysis, which is we dissolve a clot with a thrombolytic agent. You all may be familiar with alteplase, which is used as a thrombolytic agent in myocardial infarction as well. So here, alteplase is given initially as a bolus at a higher dose, and then as an infusion over 1 hour. So this is done within 4.5 hours of window. So we cannot thrombolyze beyond that in our setup because there would be a higher risk of bleeding. And the second option would be mechanical thrombectomy, where you take the thrombus out. So unfortunately, we have this facility in a very few centers in Colombo. So thrombolysis or alteplase is not a magic drug. So we have to be aware that if we give alteplase to 100 patients, it's only around 32% will be better. The proportion that is mentioned here in drawn here in dark green would be normal or better. All the green diagram would be better, but the rest drawn in white will be nothing will happen at first, but at 3 months and 6 months outcome would be better still, but the rest 6% would get worse outcome, and 3 would have significant bleeding and what would die with bleeding. So this is not a magic drug. So this has risk by itself. So what are the 4 essential steps in stroke thrombolysis? The first one is rapid diagnosis, and time is brain. Rapid assessment, early CT and CT interpretation, and making the decision to treat. So we use tools to screen patients with stroke. So I would like to introduce this tool, which is used in pre-hospital stroke screening, which is called FAST. That is, act soon, act fast. So F is for face, A is for arm, S is for speech, and T is for time. So sudden onset weakness of face, arm, leg, or slurred speech, then this could be a stroke and you have to attend immediately. So the next screening tool is the Rosier score, which could be used at the ED. So here, the importance would be we can identify stroke mimics with Rosier score. So it also has the same components as for FAST, but some additional components where if there is loss of consciousness or syncope, we give a negative mark. And if there is a seizure, again, one more negative mark. So, and the rest is same as for FAST, but there is additional unsteadiness and visual field defect or impairment to pick up posterior circulation strokes. So if there is a score of 1 to 6, we act immediately as a stroke. If you get a 0 or minus score, then we tend to think whether this is a stroke mimic. So this is our second patient. So the first patient was thrombolyzed and it was a good outcome. And this is a 65 years old female, I will call Mrs. B, with diabetes and hypertension, and last known well at 6:30 a.m., fast positive, developed faintishness, right facial droop and slurred speech, and brought to A&E at ED at 7:30 a.m. Blood pressure is normal, but her CBS was 35. So this was a fast positive patient, but she had hypoglycemia, which is a stroke mimic. So once that was corrected, she improved. So commonly encountered stroke mimics are hypoglycemia, seizures, and we know that the post-ictal state could result towards paralysis and migraine, alcohol intoxication, and other metabolic derangements, and even brain tumors, even Bell's palsy, so can be stroke mimics. So the next important step would be rapid assessment, especially Glasgow Coma Scale, NIHS score, blood glucose, and IV access, and the basic investigations, and a troponin, ECG, and to send the patient to CT immediately. I would assume that we have 2 types of audiences in this webinar, where a group of doctors or other medical personnel who has fast access to thrombolysis, or where you have to transfer the patient for thrombolysis. So for those who have to transfer the patient for thrombolysis, so FAST and Rosier are very important for early recognition of stroke, and the rapid assessment can be done by them and the initial screening, but you should not waste time for doing all these things, like blood glucose and blood pressure, and the basic vitals would be very important along with GCS, and not to send patient with low GCS, especially GCS less than 8, for thrombolysis, because it is highly unlikely that these patients have stroke, but we need to exclude other conditions that will cause low GCS. So I have this third patient. She is Mrs. C, 68 years old, patient with bronchial asthma and hypertension, presented with sudden onset left side upper limb and lower limb weakness and unsteadiness for 1 hour. So she's fast positive. So on the initial assessment at the ED, the NIHS score was 3. So this looks like a minor stroke. NIHS score less than 4 are considered as minor stroke. So we had a dilemma whether to thrombolyze or not. But then this assessment was done while she was lying down. So we got her down and we asked her to walk. where she was grossly ataxic. So clinically, this was left ataxic hemiparesis. So the NIHSS was upgraded to 5, where she received thrombolysis, and then it was a good outcome at last. So I want to highlight the importance of getting the NIHSS score correctly. And even if there is a low NIHSS score, which is a stroke disability score at initial assessment, instances like dominant hand weakness, visual field defects are instances where we would decide to thrombolyze despite a low NIHSS because of it will affect the patient significantly. So the next step would be performing the CT as soon as possible and interpreting the CT. So both these patients were from our cohort, and the first patient, you might see that he's got a subarachnoid bleed, and the next patient had a capsular hemorrhage. This was a hypertensive bleed. So it is very important to exclude bleeding on CT. So case 4, I will call her Mrs. D. She's a 48-year-old female with diabetes, hypertension, and ischemic heart disease, came with sudden onset left side upper limb and lower limb weakness since 19 p.m. and arrived to hospital at 10:25 p.m. within window. And the NIHSS score on admission was 19, and we did a CT. So if you could see this CT, you might see early changes of an infarction. Along with that, you will see this sign, a cord-like hyperintensity here. So this is called the dense MCA sign. So this is one of the signs we should pick on CT when we look at a patient with stroke, with hyperacute stroke. So this was the dense MCA sign. And there are few important signs on CT we would like to look in patients with stroke. So one thing is hyperdense artery sign. This is the hyperdense MCA sign. And we know the side of weakness, and we know the deficit would be on the contralateral side of the brain. So we always need to compare both sides of the brain. So there are special features where we have loss of gray-white matter demarcation on infarcted area compared to other side. And we have sulcal effacement on the affected side. And we have the basal ganglia, the lentiform nuclei, and all the basal ganglia are blurred. And we know the insula. Normally, the insular ribbon sign is like this. And we lose, the insular ribbon sign is lost in as an early feature of stroke. So this is objectively assessed with aspect score. So in most stroke protocols, we use this aspect score with images, but this is mainly for anterior circulation stroke, including middle cerebral artery strokes. So it is expressed as out of 10, and we give -1 if there is hypodensity in the corresponding sites. So you actually have to get your eyes used to this, and you can discuss with your consultant or the radiologist in interpretation of CTs. So the next important step would be to make the decision to treat. So diagnosis of acute ischemic stroke causing measurable neurological deficit and onset within 4.5 hours, age more than 18 years, and exclusion of all contraindications, then you can go ahead with thrombolysis. So I will not mention all the contraindication list, but you can find it anywhere. But I would like to mention a few important things, especially in unconscious patients. We have to be very cautious whether this is a stroke or something else. And past history of stroke, past history of bleeds, past history of cerebral bleeds, and known absolute contraindications are there. But past history of stroke within last 3 months would be a contraindication, but otherwise it's not. So I've told you that it's the time window would be 4.5 hours. You have to send the patient or act in or do the thrombolysis within 4.5 hours. But when the age is more than 80, or when it's a massive stroke, especially with NIHS score of more than 25, or on oral anticoagulants, regardless of the INR, and history of both diabetes and prior stroke, even the patient is presented within a window of 3 to 4.5 hours, the decision would be subjective with the discussion of the consultant. We have to be cautious in this scenario. And you may have experience at the periphery, you're getting people who are elderly, and the decision whether to thrombolyze this patient or not, a little bit of a debatable situation. But pre-morbid status, with an objective assessment of pre-morbid status with pre-stroke ranking scale, will be very useful in this situation. So a person who had been very independent with no symptoms or very without any disability at all would be a favorable candidate for thrombolysis despite of the age. And I would like to summarize the findings. You might need to tell your senior when contacting the senior before that will help for the senior to make the decision of thrombolysis. So this is a short summary, and you could express about the age, gender, related comorbidities, especially the onset time, because one more thing I would like to highlight is, for example, if we get a patient who develop weakness, who come with the history of weakness at 5 a.m. and coming towards like 7 a.m. So we think that the window is about 2 hours. But if you dig into the history, the patient might have gone to bed around 10 p.m. the previous day night. So we don't know whether this is the time of onset exactly, because it's most likely a wake-up stroke. But again, when you dig the history more, if there is a history that the patient had woke up at some point, like we consider that, assume that the patient woke up at 4 a.m. to go to the washroom. So then the time of onset changes from 4 a.m. to 7 a.m. So the interval is 3 hours. So a good history will change the decision on thrombolysis. So that's very important. And a correct NIHSS score and proper interpretation of CT brain and exclude bleeds and the aspect score. So we thrombolyze when the infarct is not visible, especially when with an aspect of more than 7, and excluding all the contraindication and a good pre-morbid status and with an informed consent. So this patient, our fourth patient, Mrs. D, so I mentioned before, this is the lady who had the hyperdense MCS sign. So she was thrombolyzed within the window period. So the starting on NIHS was 19 and it was reduced to 17. And her monitoring was normal until midnight, but she was fed by her bystander despite the advice, and she aspirated and succumbed to death, which was a very unfortunate outcome. So even though we did a proper job, we did the thrombolysis in time, and so post-thrombolysis monitoring and supportive care is very important. So initially very frequent monitoring, and we have to repeat the CT in 24 hours and to see whether there are any bleeds. It could be minor hemorrhagic flushes, or it could be extensive hemorrhage. So then we have to decide, or there may not be hemorrhage at all. So we have to decide on starting antiplatelet agent according to the CT. And it's good to avoid feeding for the next 24 hours and to avoid oral medications. And it's preferably the patient kept with the head end elevated, and usual skin care, mouth care, and it's better to avoid catheters and NG tubes after thrombolysis because there's a slight risk of bleeding. However, the half-life of alteplase is around 72 minutes, the terminal half-life, but the immediate half-life is very short, like 5 minutes. However, the general guidelines are towards discouraging catheterization and insertion of NG tube. So this is a very important slide I wish to highlight. So in my talk, one of my main objective telling you this is that we as doctors, medical personnel should try our best to achieve a door to treatment time of less than 1 hour. So in that case, we have to build up our setup, our communication systems to get the CT done less than half an hour. And then to make the decision within the rest of the period and to give the thrombolysis in a period of less than 1 hour. So in that case, we have to build up our system and so we have to be ready with the proper system to get the patients in time to the hospital and a staff who are aware and ready to accept the patient and a facility to do the CT immediately and the basic screening immediately and to give the medication as soon as possible. So I hope that I'm talking to some colleagues who do not have thrombolysis facility in their hospitals. So Sri Lanka Association of Sri Lankan Neurologists on their website have clearly mentioned and updated the places where stroke thrombolysis centers are available in Sri Lanka. So this would be a presentation where you could refer or send patients the centers which has the thrombolysis facility. So in our unit at District General Hospital Ambulipitiya, we have established a system, now it's 2 months back. So we received fast positive patients and we have established a hotline where people can contact the hospital directly about stroke before transferring the patient. And then we have a flow how the patients go through this process. And so it was a teamwork where we built up the system. And if the patient is not a candidate for thrombolysis, so it would be the routine management with antiplatelet and looking for the etiology and secondary prevention and supportive care and leading the patient for rehabilitation facility or making the referrals for rehabilitation, especially with physiotherapy, occupational therapy, and speech therapy. So the other important thing I want to tell you is how we can develop a thrombolysis facility in our center. So mainly we have to aim on training the staff, the doctors, the nurses, radiographers, and the supportive staff. And we should have a protocol, a hospital protocol, how we should do this in our setup. And we should establish a pathway inside the hospital and make it visible to all. And we have to improve public awareness and then to monitor the process. Thank you very much. And I would like to take this opportunity to thank Sri Lanka Stroke Association and Association of Sri Lanka Neurologists, Dr. Harsha Gunasekara, Dr. Padma Gunaratna, Dr. Harsha Fernando, and my colleagues at District General Hospital Ambulipitiya, the director and the physicians who immensely supported on this. And I would like to tell you that Sri Lanka Stroke Association is very kindly willing to provide you the support to establish a stroke service in your hospital. Thank you.
Thank you, Dr. Anomali, for very interesting and very informative presentation. And we will discuss questions at the end of the next presentation. The next speaker today is Dr. Lakmal Vithanage, Consultant General Physician, BH Udugama. Dr. Lakmal Vithanage, MBBS, MD, overseas training at Bedford General Hospital, UK. He served in many hospitals in Sri Lanka as a consultant general physician, including DGH Monaragala, BH Kilinochchi, DGH Hambantota. He is going to present on Prinso poisoning burden at a local hospital. Over to you, Dr. Lakmal.
Good evening, dear my teachers and all colleagues. So I apologize for the delay. And straight away, I will go to my topic. I thought of discussing with you about the Prinso, one of the. Hello.
Yeah, we can hear you.
You can hear, right?
Yeah.
Detergent poisoning, which is commonly seen during my presence in the Udugama hospital for nearly 15 months now. And so as a beginning, I would like to give you a little introduction. So this has been the common household detergent for many years, more than 20 years. And when I see the past cases and some of the case reports and studies, this has been studied and reported many occasions in the past. And there were good studies done at TH Ratnapura, as well as some cases in from the Mathura, giving the importance of this home simple, cheap detergents, but causing a lot of damage to the socio-economical impact of the for the many people in the mainly at the southern and Sabaragamu area, according to the cases. And during my period also, I saw throughout the year we are getting patients with this kind of poisoning, and the leading to the many occasions because of the freely availability, and it's little cheap. And also though this is happening for many years, the policies has not changed by the government, so it's keep on happening, and a lot of admissions we are getting. So this is the picture of the commonly seen one packet, but there are many names coming up with the same content inside. So this is the Prinso, but it will come with the different letters using the, I think they are using the competitive marketing. So they use the different names, but having the same component inside. In your right side, you can see in the packets, in the two sachets, the main components of this packet. The blue color, deep blue or purple color one is the main one chemical. This is potassium permanganate. The other one is the white powder, is the oxalic acid. So these two agents use as a in Sinhala they name puskudu, which mainly used to remove the fungus in the clothes. Usually children, it's a wet zone. I think they get a lot of fungus during the wet season. So people like to use this cheap option to remove the fungus. And the oxalic acid is whitish, is a main corrosive agent in this packet, and it contains around 10 grams. And it has the main side effects done by the oxalic acid. And the KMNF again, but it contains around 0.5 to 1 gram in a one sachet, and it can cause corrosive effect as well as methemoglobinemia in the high doses. So I will move to the next slide. This is the where I bought my sample, and you can see many packets already gone and sold by this boutique owner. And I'll start one patient to discuss with you and discuss about the other patients. So this Mr. M, 53-year-old male, he admitted after ingestion of 2 packets. I think he has taken the white color, the oxalic acid packets, And some people take both, and some people selectively take one. The choice may be depending on the color and the size. And he mixed 2 packets in the cup of alcohol and taken. But because of these corrosive effects, these people can't hide the thing. So they usually start with abdominal pain, nausea, and start vomiting. Actually, because of the size of the packs, he started vomiting blood. So people brought him to the local hospital, and then he was brought to our hospital by ambulance. In our ETU, we also did our initial management, and in the ward, once he came to the ward, as we see that his urine output is low, and he has gone to the kidney damage. So by experience, we know when it comes to the patient, what the kind of injury already happened. So it's a common outcome. And but this it may vary with the patient, but this one didn't make any urine for 48 hours. We kept 1 day in the ward and then admitted to the HDU for close monitoring. And the third day, after the 48 hours, decided that he's not making urine and his creatinine is going up, and electrolytes has pH values close into its upper margins. And discussed with the consultant on call at Karapiti at that day, and discussed with the nephrology team and transferred for the management. So he underwent 3 dialysis during Karapiti ward stay, and is that taken 10 days uh, for the complete course, and almost 14 days in the total hospital stay. So you can see how his creatinine crept up from initially 2.3 very first day, and the day 2 4.6, and it went up to the 7.2 when at the verge of the first dialysis. And again it dropped, and for the within 2 days it make up to 9.4, and day for the before third dialysis again 4.9, and then with the urine output increasing, the creatinine level came down, and the urine output improves after the 12-13 days. So, and he went home completely with a good outcome ultimately. So also, I want to highlight a few things about this detoxification. Fortunately, we have good antidotes, but if we have to use it timely, because oxalic acid, in my experience, when it absorbs very quickly. So we have to give the antidotes uh, early, and it's cheap. The main one is a calcium carbonate or calcium lactate. They advise to give crushed tablets, maybe 20-30 like number of tablets to uh, like to uh, bind with oxalic acid in the stomach and make it calcium oxalate, which is not absorbable at the gut. So that main part depends on the detoxification before absorption in the gut. So, and then IV calcium gluconate we start same time to help hypocalcemia, because whatever the amount absorbed from the gut in the circulation, they bind with the ionized calcium and patient goes into the hypocalcemia. So other options are activated charcoal, and even we can give milk to drink which contains calcium, and that will also help to minimize the oxalate absorption from the gut, from the stomach. So ultimately, when the calcium oxalate deposit make up in the blood, that will go and uh, uh, stuck in the tubulointestinal in the glomerular tubules and causing tubulointerstitial nephritis and making the patient acute kidney injury. So we start calcium gluconate very early to treat or to mitigate the hypocalcemia. And when I go through the case reports and studies, they mention that there had been many deaths in the past. For in my patients, fortunately, I didn't have that deaths, but all other serious complications. So these are my little statistics experienced during this 15 months. I got 21 admissions for the male ward, but out of high, the number is total number is high, so it consists 0.6. In female ward, only 5 patients, and it consists of 0.2% of admissions. But I think, and they stay usually the when the Prinso patient comes, majority recovers, but they stay 4 to 5 days in the average to see the effect, and some they need psychiatric referral also. So total days little goes up, and also if they become complicated, one of the I will discuss the complications later. So the time become more, maybe 2 weeks, like in my previous index case. And but when we talk about the major cases that we manage in the wards, the number of admissions, this higher number is mainly because of simple admissions. They come with maybe blood pressure control, maybe sugar control, faintishness, like simple complaints we manage. But when it comes to the major cases, this proportion goes about I think 6 to 10%, like goes up. So it's a, I think when we consider the significant the patients, this proportion is high. So I had a little analysis about the age distribution among males. I think it's distributed from teenagers to adult in a nearly equal pattern. So I have seen some very old, like 80s old people also taking this uh, as a self inflicting poison. But in my group, this female number of females were low, as well as they are low. Most of them were young girls. And some studies has shown, in Mathari study, they have shown at that time the female predominance. This is little opposite to that study according to the details. And these are the outcomes. The principal is in majority of patients develop the epigastric burning pain. So they complain the burning pain that indicates corrosive effect on the gut, but the absorption amount that they absorb is little, so their renal impairment is minimum or not detectable. So they recovers with some IV furosemide, some fluids, antacids, and simple 2-3 days time we can uh, come to the conclusion that they are not having serious poisonous effects. But acute kidney injury is one common thing. Out of 26 patients in my group, the 7 patients went into the acute kidney injury, and but only 3 patients needed hemodialysis. But that proportion is little high, nearly half. So all patients need to go to the transfer to the Karapitiya for dialysis. These 7 other patients, we use our usual ways to manage, like giving fluid and giving furosemide and having close monitoring with electrolytes, uh, serum creatinine, uh, and close monitoring, so we can make the urine output better. And sometimes we have managed patients with creatinine around 5-6 in our HDU, but usually they recover. So that's a good aspect of this initial good management of the Prinso poisoning. And the hematemesis is the other common complication because of the corrosive effect of the oxalate. They start some blood vomiting. So out of 26 people presented with hematemesis or had the history of hematemesis, and but it's controllable. I have not seen seriously bleeding and going into shock. And the hypocalcemia, again, the well-known complication, but I could not test and get the results because it was not intentionally done because these cases I retrospectively assess. We usually start giving calcium gluconate from the ETU. So we know the effect, and so we start treating rather than checking the calcium levels for 2-3 days. And methylglobinaemia, again, the effect of the potassium permanganate poison, it causes ferrous to ferric because of its oxidative effect. But fortunately, this packet contain only 0.5 to 1 gram of KMNO4, which does not cause lethal level of methylglobinaemia in a normal person. So far I have not seen cyanosis or not bothered to give methylene blue in this group of patients. And when it comes to the final and the detrimental death of these poisons, fortunately, I did not witness any serious illness or death of these patients. But in the Ratnapura, the one study done in Ratnapura, actually it was an autopsy study done by the consultant JMO during 2015 and 16. They have identified 16 deaths due to the Prinso poisoning, and all had this acute kidney injury, severe corrosive effect on the gut, stomach, and some congestion in the liver. So so they have shown the seriousness of this poison or chemical, taking chemical as a poison. And also the Ratnapura and one other study from 2070 to I think 2023 years, they have got 270 odd cases during that period as admissions. But I think because of the awareness of the people as well as our experience more and more in the ETU level, now the death rate is coming down. That's a good thing. And again, I thought of this aspect as well because the cost also now previously we didn't talk about the cost and we didn't bother as we are clinicians, we are trying to treat the people and send home. But this aspect came to the picture like with some several lectures recently heard that Karapite, our goal GMA lecture also, there was interesting lecture about the cost. So I also thought about what's about the cost of managing these patients. So actually, when I got some information from our office, they calculated roughly about a bed cost for the bed without medication. It costs nearly 5,000, but without extra duty or other salary, with the basic salary of the team, they calculated this. This is a rough amount, but may change with the hospital to hospital. In Hambantota, it costs around 13,000 when I talk to them, and Karapiti, I think more than this. And the HDU ICU cost is more high, and the dialysis cost is nowadays, I heard that is around 12,000, and to all the tests to be done before first dialysis, it costs around 11,000. And I just had a calculation for my patient, index patient, without cost for the medicine, it's more than 1,500, 150,000 rupees for the total management is a minimum cost. So not alone that I have seen they are losing their income, because majority of these people, especially the males, are in the middle age, so they are the breadwinner or a main income for the family, so they lose their income capacity for maybe more than 2 weeks, and their expense, and during the admission they have a lot of other expenses as well. So this time is not good, so some test medications they have to buy from outside, and traveling is not cheap. So, and also the children, they lose their schooling training, and also the psychological damage we can't estimate. So altogether it's a big cost. So, and also uh, due to this socio-economic environment, I feel that the number of patients will be more and more in the future and need some preventive measures. And and actually we need some cheaper non-toxic alternatives to use in the use of these stains or fungal changes in the clothes or stains, or to make it unpalatable. Actually, that ragam study by the JMOs, they have suggested. So this poison should be more difficult to take, or bad odor or bad taste should be incorporated when it is come to the use in the community. But it has not happened so over the last 20 years. So this Prinso has become a better choice because of its inherent main features, like it's cheap. Nowadays it's 80 rupees per packet, and it's available everywhere, from the boutique in the village to the, I have seen it some supermarkets. And also it's odorless, tasteless, and less corrosive to the mouth, so they can swallow it. And sometimes colorless when you take the white one, and the other one is a for it's a purple color. So those are not the odd colors for the people to drink. And ultimately, but when it goes to the stomach, it's very highly toxic and having the bad outcome, and a lot of complication, and it's a deadly poison. So as a part of my work in the base hospital, we only few cases we transfer to the teaching hospital or a centers for the facilities, but we bear the weight of many other patients using our healthcare facilities, our manpower. So I think I feel like these are preventable things, preventable cases, and we take some actions to support to people to avoid or to find alternatives using our either through colleges or our connections to share our facilities among the needy people. So that was my target. And thank you for giving me this opportunity, Ceylon College of Physicians, and dear President and the Council, and also Dr. Rohit Amaritana, who helped me to build up this talk today, and giving me the support behind. And thank you for the whole audience.
Thank you, Dr. Lakmal, for sharing your experience of Prinso poisoning with us at the local hospital, which caused a significant burden at the periphery.
Dr. Anomali, will you be happy to answer a question? We have a question here asking, where CT facility is not available, what are the initial measures that we can provide for patients that will help better patient outcomes? And what are the common pitfalls in managing stroke in periphery where CT is not available?
Yeah, so what we can do is, like, the most beneficial thing would be correct recognition that this is a stroke and not a stroke mimic. And then with initial basic management, like, you have to make sure that the patient is not hypotensive, not hypoglycemic, and not in any other critical illness or any other critical state which might harm his life. So then transfer the patient immediately, because giving aspirin without performing a CT in a suspected acute stroke could be harmful, because we don't know whether it's hemorrhagic or ischemic. So mainly consider or focus on stabilizing the blood pressure, the glycemic control, and the other thing would be the airway, and transfer the patient immediately. And otherwise, like, if you get patients like a delayed presentation, but however, I think you have to get the CT done to establish the diagnosis. And what we have noticed are, like, receiving patients with very low GCS, which are not stroke, and receiving patients with hypoglycemia or seizures with transient paralysis, which are stroke mimics. Other scenarios I have observed, which should have been not happen if the doctors have given more attention on the scenario.
May I ask another question from Dr. Anomali? So, what are the practical challenge? What are the challenges and practical difficulties you face when you start and continue thrombolysis for stroke patient at Ambilipitian?
Yeah. So I would mention the immediate practical problem I'm facing now. Because when we started the thrombolysis program, we had a public awareness program. Actually, there were a few programs. So during a period of 2-3 weeks, we had a lot of patients coming within the time window. Some of them were stroke mimics, but nowadays, like that public awareness is becoming lesser, and we again see patients coming with delayed presentation. That is one thing. And the other thing would be getting the whole team to synchronize into something like this, especially with regard to imaging, and get a proper door to CT time is a challenge in our setup. Because with the current situation, at times we don't have radiographers available around the clock in some centers. So it is like the best thing would be to make the whole team, whole relevant team, aware of the importance of this the process, and doing this early, and why we do this, and to emphasize that we will save the life of either them or their relatives, their loved ones, so that the willingness to contribute to this is the most strength on this. And then the teams will willingly cooperate and participate for this to achieve the time targets. That is one of the main challenges.
Okay. Thank you, Dr. Anomali. Also, there is another question in the Q&A box. Again, the question is it still the practice to consider the midpoint between going to sleep and waking up as the onset time of the stroke, wake up stroke?
Because that's an important question. However, because we don't have MRI facilities or CT perfusion for advanced imaging, we consider the time the patient went to bed as the onset time, not the time in between. So if we have more advanced imaging like MRI with diffusion DWI, so we can image in a better way. But the onset time would be the time where the patient went to bed in a wake-up stroke.
Okay. So, Dr. Anomali, another question also for you. What is the place for IV tenective place for thrombolysis?
So actually, there are a few trials going on where tenecteplase is trialed with alteplase and even with thrombectomy. So it is not approved as yet, but in coming future it will. So far, it has shown non-inferiority. So because of the cost effectiveness and easiness to administration, in the future, it will appear on the guidelines, most likely, but not yet.
Okay. Thank you, Dr. Anomali. Now we are coming to the end and first let me to thank two speakers today, Dr. Anomali Shilpika Vidanagamage and Dr. Lakmal Vidanagamage, for accepting our invitation and for their excellent presentations. Also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor Merck Pharmaceuticals for their continuous support, and all of you visual participants who are joining with us today.